Hello. Today we're going to talk about coronary artery disease. We've been talking a lot about the anatomy of the heart and the physiology of the heart. So the structure of the heart, the electricity of the heart, and how the heart should function. And today's focus is going to be on coronary artery disease. So what can start to go wrong with the heart? We've talked about previously how the heart has a large workload to do. Its job is to send blood and oxygen throughout the body from the brain down to the toes. So it has a large workload to do there. But because it itself is a working muscle, it needs its own supply of blood and oxygen. And it gets that through the coronary arteries. So a small a bunch of small arteries that spider web over the heart and deliver that blood and oxygen. And over the course of our lifetime, they can develop some wear and tear in those arteries. And we call that little nicks and dings in those arteries that supply the heart. And so just over the course of our lifetime, there can be some wear and tear there. And then if we are doing things that accelerate that damage, maybe we are smoking, or maybe we have consistently high blood pressure, or blood glucose numbers that are not well controlled. Those types of risk factors for coronary artery disease can accelerate that process of the wear and tear in those vessels. So that's what we're going to focus on today. What the body tends to want to do is, if it has some damaged area in the inner lining of that blood vessel, our body wants to lay down plaque or cholesterol as kind of a Band-Aid layer so that blood can flow smoothly through that artery. So the more damage that we're doing by having risk factors for heart disease, and we will talk a lot more about those, but also by having more higher levels of cholesterol in the body, that just accelerates that process of that plaque building up in those arteries that supply the heart with blood and oxygen. That process is called atherosclerosis. So typically when those blood vessels get to be usually about 70% or so blocked, that's where we can start to have some, potential symptoms that something is going on in there. That might be the point to where your cardiologist is having conversations with you on whether they want to do some type of intervention, whether that be a stent or a coronary artery bypass graft, or maybe they just want to continue to monitor that and to medically manage that area. So, talking about good, healthy nutrition, exercising regularly, and then putting you on certain medications, and then just keeping an eye on the situation. And first, let's talk about angina. So angina is a symptom that we can get if there is a partial blockage there in our coronary arteries. So typically when we would feel those anginal symptoms are when we are exerting in some form. Maybe we're doing the stairs or exercising or that kind of thing. This is where you've got a partial blockage there, and the heart is needing to push more blood and oxygen throughout the system. And so that's where you typically would feel those symptoms. If there's a blockage there, the heart is not getting the amount of blood and oxygen that it needs, it would generally then tell you in some form of anginal symptoms. And I'm going to read through these symptoms just so I don't miss any of them. But generally, angina, we want to try to avoid just calling it chest pain, because for some people it's not painful, and for some people it's not in the chest. So we want to, if we went around the whole room in cardiac rehab and asked people if they've had angina before, what those symptoms felt like, those symptoms can really vary. And so I just want to cover all of these. But it could feel like chest pain or pressure. This could also be a feeling of tightness or pressure in the neck, chest, shoulders, jaw, or between the shoulder blades in the back. So we typically say nose to navel, front side or back side. If you're exerting and you feel that symptom come on, we'd want you to slow down and see if that symptom diminishes, and let the staff know those are symptoms that we want to not push through, where, that means your heart is temporarily being deprived of blood and oxygen, and we want to make sure that we're giving our heart all the blood and oxygen that it needs. So we'd always want to back that intensity off and let that symptom diminish. Sometimes people can feel shortness of breath with that symptom, tingling or numbness, or feeling of upper stomach indigestion or fullness. So again, any of those symptoms that are kind of nose to navel, front side or back side, that come on exertionally is typically how people describe angina. And those are symptoms that we will talk to you about wanting to keep track of. Usually we'll provide some form of an anginal log, and we want your cardiologist to be aware that you're having that symptom. If it's a new symptom for you, after an intervention like a stent or a bypass graft, and this is the first time you're getting that symptom again after that procedure, it would be good to give them a call and just notify them that that symptom is returning, especially if it mimics those anginal symptoms that you got before your stent or bypass, if you did feel those symptoms prior. And a lot of times that would mimic those same anginal symptoms, but not always, but a lot of times it would. So it's good to notify them if those symptoms are returning. At that point, they might want you to just keep an eye on it, tracking those symptoms on that anginal log. And at that point, we're watching for red flags that something is worsening. Are you starting to feel that symptom more often or more severely, or with less and less effort? And so those would be red flags that we'd want to call our cardiology office back and give them another update that we are seeing these symptoms progress. So keeping in good communication with your cardiology office and our cardiac rehab staff. But these symptoms, you typically, go away. They're not necessarily causing permanent damage. We just want to make sure we're not pushing through those symptoms. We want our heart to get all the blood and oxygen that it needs, especially when it's trying to heal. There is also a big push for education out there to educate women and everybody that a lot of times women's symptoms of angina aren't as easy to recognize. So I kind of talked to you about some of those typical symptoms of angina. A lot of times women or people who are diabetic might not feel those symptoms that are more typical. Our symptoms might be more atypical. We might feel more flu-like symptoms. We might feel more excessively fatigued or excessively short of breath. And that's one of the reasons why women tend to have worse outcomes from heart disease, because we don't recognize our symptoms as being heart related soon enough to get good treatment, or possibly, having those symptoms misdiagnosed. So you kind of know your body the best, and really just watching for those types of symptoms, especially if they're coming on exertionally. All right, let's see. So that would be anginal symptoms. And then what's the difference between that compared to having a myocardial infarction or a heart attack? So if you are having a heart attack, that occlusion that we were just talking about in the coronary arteries, that's now completely or almost completely blocked, to where blood is not supplying the area of heart tissue below that blockage. And that's where they say time is muscle, and we need to get into the emergency department as quickly as possible, because where that heart tissue does not receive blood and oxygen, it starts to die, and that does cause permanent damage. So we want to get in as soon as possible. Typically, we advise that route be via ambulance or calling 911. And so they have, trained staff there on the ambulance, or however they recommend that you're getting to the emergency room, to help get you in as quickly as possible. They have medications on board. They're able to quickly, more quickly diagnose if that is an active heart attack that you're having. And so that's generally the safest route getting into the emergency room. We typically try to steer people away from just driving themselves, because if you were to have worsened conditions en route to the hospital, that's where that could put you or others at greater risk. So typically we recommend calling 911 and getting in as quickly as possible. So if you're having those anginal types of symptoms that are not going away with rest, then that's typically when we would want to call 911 and get into the emergency room in case that is an active heart attack that's occurring. And it's typically not the case that you have that plaque buildup in the arteries that's gradually over time occluded and sealed off that artery completely. That can happen, but the most common cause of a heart attack is that that occlusion there, if there's a partial occlusion and it's become unstable, partly due to levels of inflammation in the body. And this is where we'll also provide you with more information in the class on the inflammatory process. But we want to make sure in our bodies that we don't have too high of levels of inflammation, because one of the effects of that is it can create unstable plaque in the arteries, and where that plaque becomes unstable, it can break off and rupture there, and where it's ruptured, a blood clot can form and occlude that artery. So we don't spend a lot of time in the classes focusing on inflammation, because where we are focusing on reduction in cardiac risk factors, like not smoking, watching our blood pressures, exercising regularly, those types of things, those also reduce levels of inflammation in the body. They go hand in hand. So that's a good thing there. But we want to make sure we don't have too high of levels of inflammation in the body to keep that plaque. If we do have plaque in the blood vessels, make sure it's stable and not rupturing. So we will provide you more information on that if you would like that in the classes. Okay, so that's the difference between angina versus having a heart attack. And let's also touch on nitro. So nitroglycerin is an emergency medication that some of you might be carrying or might be prescribed. This medication is a vasodilator. It's an emergency medication to where if you're feeling that anginal symptom coming on and you try decreasing that intensity level, that's not improving that. If you sit and rest and that anginal symptom is not going away, that's where you would follow that nitro protocol from your pharmacist or your cardiology office. And typically our process is that if that anginal symptom is not diminishing or going away within that 3 to 5 minute period, you're taking that first nitro underneath the tongue and let that dissolve. Or if you have the spray, you would utilize the nitro spray. But being seated and waiting that 5 minute period. And we would be monitoring your blood pressure in class. It's a vasodilator, so where that opens up those blood vessels to try to allow blood through that partially blocked area. Your blood pressure would also be dropping because of those blood vessels opening. So we would be making sure you're hydrated. We would be checking your blood pressure and waiting that 5 minute period. And so they typically recommend that if you're going to have to take that second nitro, if you are at home alone, maybe having somebody on the phone with you, even if that's 911, just telling them that you're going to have to take that second nitro, just because of the potential for that blood pressure to decrease too low to where it makes you, dizzy or have a low blood pressure episode. And you would repeat to no more than 3 total nitro is the recommendation. If your anginal symptoms are not going away after that, after three nitro, you're definitely calling 911. Or even if you're going to have to take a third nitro, we recommend calling 911. So those are kind of the process usually that we typically recommend for that nitro procedure. But if you have any confusion there, reach out to our staff, reach out to your pharmacist or your cardiology office. They are great resources for you on that nitro protocol. We usually want you seated when you're taking that medication just in case your blood pressure does come down a little bit. That nitro should typically be kept in the original container there in a dry place away from heat, humidity, and light. And be aware that it does have an expiration date. If that seal is broken, there is typically an expiration date. I want to say it's about 3 to 6 months, but double check your prescription, double check with your pharmacist. If that seal is not opened or broken, that expiration date would be longer with, years. So I would check your prescription, check with your pharmacist, and just make sure you're aware of when your prescription for that nitro expires. Because if you did ever have an emergency situation where you need to take it, you want it to be a current prescription that's actively working the way that it should. Let's see. So those were the main points I wanted to touch on today. So kind of big take homes from today are, kind of, your body the best. Kind of know your anginal symptoms. If it's something that you have felt in the past, if something is returning, make sure you're paying attention to that, keeping in good contact with your cardiology office on that, being a good advocate for yourself if anything is changing. And those, I think, were the main points I was going to touch on today. We'll likely have some handouts if you want more information on some of those things we discussed today. All right, thank you.